My name is Guillermo Garcia-Manero from the Department of Leukemia at MD Anderson Cancer Center, and I'm going to be talking about some therapeutic options for patients with high-risk myelodysplastic syndrome. So this is a proposed algorithm from a paper that I publish every couple of years in the American Journal of Hematology. If you compare these two prior versions, we are starting to see some changes to this treatment algorithm. And I think eventually we're going to really have in the next few years some significant improvements for our patients, both in low risk and high risk disease. But as you can see in this kind of a schema, we divide patients into lower risk and high risk disease. We're going to focus on the right on the high risk patients. You can define them by IPSS. That has been the traditional criteria since 1997. This was updated or upgraded by the IPSS-R. And then most recently, we had a new molecular classification of this disease known as the IPSS-M. What you see is that we take into consideration age for our patients and whether the patient is a candidate or not for induction therapy, for bone marrow transplant, and of course for a clinical trial. So one of the things that is really happening right now that is really interesting is that we're seeing the incorporation of molecular biomarkers into the prognostication of patients with MDS. So this is the table from the Peter Greenberg revised IPSS paper, as you can see, from 2012, so 10, 11 years old. Very simple classification using blast, cytogenetic cytopenias, more detailed than the original IPSS, and basically dividing patients into so-called lower risk, maybe very low, low, some intermediate, and high risk, maybe more than 3.5 points high and very high. So this is actually still the standard classification that we use today for our patients. Then over the years, we develop a number of therapies, in particularly these hypomethylating agents. And we work with this agent in particular called azacitidine that has become, or is still today, the standard of care in view of the results of a very important trial in this field known as the AZA-001 trial. This was a large study led by Dr. Pierre Fenot, randomizing azacitidine versus a standard of care that could be low-dose cytarabine. Some patients receive high-dose chemotherapy. And what you see here is that the survival on this trial with azacitidine upfront in high-risk MDS was around 24 months versus 15 months. Reality is that probably this 24-month survival is significantly shorter than that in real life, maybe around 17 months or so. But this still is our kind of data to beat in next generation trials. We also had in those days kind of limited, if not to say, in my opinion, mediocre transplant data. So this is an analysis by the CIBMTR. You see that from 2013. This is a very large study from multiple centers around the world. This is kind of a Monte Carlo analysis, as kind of predicting outcomes. And what you saw that is in MDS patients that tend to be older, receiving reduced intensity transplant, the reality is that there was maybe a benefit for a subset of these patients, but at the expense of high mortality upfront. And in general, actually, let's say a decade ago, we were not really transplanting a lot of our patients with high-risk MDS. So that's kind of like where we were, let's say, 10 years ago with this disease. Around that time, there was a very significant effort in trying to understand this disease molecularly. And this is one of 4 very important papers, but I always use this graph because I like it very much, from Dr. Papa Manuel, who was in Cambridge in those days, now at Memorial, basically doing a molecular analysis, trying to analyze the frequency of these events in a very large international cohort of patients with this disease. And this actually has been validated, as I said earlier, 3 or 4 times. And you can see that there are a number of genes like SF3B1, the most commonly mutated, TET2, DNMT3A, etc. So this actually allows us to understand at the molecular level this disease much better. Now, from the beginning, people like me were interested on seeing whether this gene data could have a prognostic value. So this is actually one of the first efforts. This is by Dr. Montalban at MD Anderson, very simple analysis, but in a very large cohort. And what you see there, for instance, is those patients that have, let's say, 3 or more mutations had a very poor prognosis, similar to that of what you see, for instance, for those patients having a P53 mutation, and actually as predictive as just applying the full IPSS-R classification. So this kind of data gave us this information that molecular features could really help you in determining the prognosis of your patients with this disease. So that led to this very large international effort. This actually took quite a bit of time, almost 10 years, as you can see there, that is now known as the IPSSM. This was also led by Dr. Papa Manuel, has been presented by Elsa Bernard, and published in New England Journal of Medicine Evidenza last summer. So this is a very important effort. And actually, it's very satisfactory to see this because it's large international cooperation and kind of like a free thing that you can actually calculate if you just have access to internet and you click IPSSM. So basically, this tool that is summarized here incorporates the criteria that we used to use on the IPSSR. It also adds age directly to the model. And then if you use it, you will see that it's going to ask you, on top of age, white count, hemoglobin, platelets, neutrophil count, what is the age of the patient? That's very important in my opinion. And then it's going to ask you, okay, what are the cytogenetics? For that, we still use the IPSSR cytogenetics. And then it's going to ask you, does this patient have a P53 mutation or not? That's critical. It's going to ask you kind of whether this is a biallelic or monoallelic mutation. I'll explain that in a second. And then it's going to ask you, do you have any of these other mutations? Yes, no. And basically, automatically, it gives you an output that is very clean, and it will give you both the IPSSR and the IPSSM, which is actually, in my opinion, something that they thought very well and is wonderful because you will have the classification that maybe you have used for 10 years plus this new molecular classification. And you will see, I don't have time to go through this in this talk, that there's actually some discrepancies. So what you will see when you apply the IPSSR and the IPSSM in parallel is that many times, particularly in patients with low and intermediate risk disease by IPSSR, the risk increases by the number of mutations. That's actually a very important phenomenon. Now, the other major difference with the IPSSM as opposed to the IPSSR is that if you notice on the prior slide, the IPSSR divided patients into 5 groups, whereas the IPSSM is now 6 groups. So the very low, low, moderate, low, moderate, high, high, very high. So this allows for an easier dichotomization of our patients into lower versus high risk disease. Now, although we are excited about this IPSSM, the reality is that it has not 100% being validated yet. So there is some very nice data out of Europe in JCO by De La Porta indicating that, for instance, in the transplant context, this works very well. But we don't have actually good data that in patients treated with a hypomethylating agent, or maybe in patients with what we call HMA failure, hypomethylating agent failure disease, this tool will work as robustly. So those studies are actually ongoing, and I think we're going to see quite a bit more data.
Can I just ask you something that Dr. Salomon said that kind of surprised me? I'm curious whether you agree with it. So I asked him, how do you manage a patient who under the old system was low risk, but under IPSSM, they're high risk? And I was expecting to say you manage them like a high-risk patient. He said, no, you still manage like a low risk, it's just the prognosis is worse. Is that true?
I think the answer is that we don't know. So this is a very important question, Neil. This actually, you just hit the nail with the hammer right away. Because what's happening now is that there are situations where you could have a low percentage of blast, not a lot of cytopenia, but a number of mutations, let's say 3, 4, 5. Then all of a sudden, this is a high-risk situation. And it's not that you will treat them as low risk, it's that we don't know exactly what to do with this particular group of patients, because how do I change that natural history? We don't know. In the past, we will have no molecular data. We will call this low-risk disease, and we will observe or give growth factor support. Now, this is not clear. So I think this is an area of research now that is becoming very important. So for instance, in our group, we're starting to think about more active kind of hypomethylating agent-based therapy for this group of patients, but that should be done probably in the context of a clinical trial right now. Like, you're not ready to say, okay, you have poor prognosis because of the IPSSM, therefore I'm going to do Y.
Perfect. Thank you. Please continue.
So basically, going back to this IPSSM, I think this is a very important tool. As has been alluded earlier, it allows you only to predict prognosis. I'm not sure that we're ready to infer a lot of therapeutic decision-making based on this molecular data, but I think it's going to come. Now, the other thing is that this is not universally accepted, meaning in most countries, they don't have this kind of data. Or if they do, it may take them a month or 2 months or whatever it is to get this kind of data. So what is going to be the applicability of this kind of assays in the overall community is of interest, and we'll have to see what happens. Now, with that, let's start with the first patient, Neil, that is a 78-year-old man. This disease is more frequent in males than in females, that comes to the clinic with a history of cytopenia. You perform your bone marrow exam, you have 15% blast, patient has a trisomy 8, and you do this NGS assay, and the patient has TET2 and DNMT3A mutations that are very common. So basically, this is a patient with higher risk disease. 78 is at the kind of limit of what we transplant or not in places like MD Anderson, but let's say our patient is not a candidate for an allogeneic stem cell transplantation. And then the question is what you're going to offer him. So the standard of care will be a hypomethylating agent, and you discuss with the patient that right now we have 3 of these drugs available for our patients in the United States that include azacitidine, decitabine, and an agent known as oral decitabine cedazuridine was approved a couple of years ago for this patient population.
Could I just ask, in this case, does the fact that the patient had 15% blast affect the way you think through this? And, how do you decide whether this is high-risk MDS or AML?
That's a very good question, Neil. So there's a lot of controversy now that I think is not really needed, but you brought a very important point. That is, traditionally, we have described these entities using WHO criteria. So the World Health Organization has these efforts that we all agree, the famous Blue Book. So apparently, and I don't know the politics of this, a group inside this WHO came out, it's called the ICC, and they've been in parallel coming with their own description criteria of how to upgrade this classification. So the 5th edition of the WHO still maintains blast up to 20%. This ICC decided to call this entity from 10 to 20% blast as MDS AML. This is creating quite a bit of controversy. My opinion is that we should use 20%. If indeed, actually, probably some patients up to 30% will be considered MDS. But there's a lot of argument about this. So why, my understanding, this ICC group of investigators thought that it was pertinent to decrease the threshold of blast to 10% is because, quote unquote, this could help with clinical trial design or making access to trials easier, or maybe incorporate AML therapies that we use faster into MDS. I personally don't understand that. I think diseases are diseases. They have a name and they have probably different cell of origin, different characteristics. So it's like you're saying, I have esophageal cancer with a RAS mutation and maybe colon cancer with the same mutation. Let's not call it esophageal cancer because we kind of treat it the same way. So I don't really agree with this idea of making practical considerations into this type of situation. That said, to finish this long answer, this question, if this patient was, let's say, 55 years of age, yeah, that would be very important because at MD Anderson, we treat these patients with an AML-like program. It doesn't mean I need to call him or her AML. I treat them with AML, with therapies that mimic AML. So I don't know what I need to change names of a disease based on the type of therapy. In a 78-year-old, the data for the last 20 years will really not support the use of intensive therapy. So here is the age of this individual that will make you not that excited about that approach.
Well, let me ask you, what happens if you give 7+3 to patients with high-risk MDS?
It depends on the age. So in general, that's actually the ASA00 trial. That's the slide that I showed you earlier. It was not superior, it's probably inferior to the HMA, but that's if you take all comers. Now, if you take younger patients with this disease, where the goal, for instance, is a stem cell transplant. So this disease, although it can happen in the mid-70s, it happens in people in their 40s. So if you have someone like that, okay, you'll give them induction therapy, and probably you will try to take them to a stem cell transplantation as soon as possible, meaning like a month later. That's a small proportion of these patients. Majority of them are in the mid-70s, where these kind of therapies are inferior because they have too much mortality. So actually, this is data that goes back almost 15, 20 years ago. And I think the community is forgetting about this because this analysis was done. The response rate is higher with the 7+3 or whatever you use, but the mortality is also higher. Whereas with the azacitidine, for instance, the mortality is lower. It takes a little bit longer to go, but at the end of the day, the survival rate is probably better with the HMA than with the chemotherapy. It's safer, less intrusive. You don't have to be a month in the hospital. So chemo was abandoned like maybe around 15 years ago for this group of patients.
Okay, please continue.
So going back, so we offered this patient these three different modalities of hypomethylating agents, but over the last couple of years, there's been quite a bit of interest on the development of these oral drugs, these oral hypomethylating agents. Why? So both azacitidine and decitabine are the standard of care for our patients with MDS and actually older AML. But both drugs require 3 to 7 days of intravenous subcutaneous administration. This is actually a lot of time for our patients. These drugs need to be maintained for as long as possible. So I have patients on this like decades, not decades, I'm exaggerating now, but over a decade on this kind of therapy. So we're talking about chronic therapy for a long period of time. And also the field is really evolving into these oral combinations like venetoclax is an oral compound. We'll talk about this a little bit at the end. And there's a potential for transplant. So there's always been, since I was a junior faculty when we started developing these compounds, interest in developing oral hypomethylating agents. And actually, there are two approaches to do this. One is what you see on top of this slide, where you combine the hypomethylating agent with another drug that is a cytidine deaminase inhibitor. And I'm going to explain in the next couple of slides what this enzyme does. There's another approach, I don't have experience with this, with an agent called tetrahydrouridine that is also being investigated. The other option is just to do and combine HMA. This is actually what the oral azacitidine or the CC486 is. Now, CC486 is approved in AML, not in MDS, so I'm not going to discuss it here. So basically, the approach has been to combine this hypomethylating agent with this cytidine deaminase inhibitor. Why is that is shown in the slide. So basically, cytidine deaminase is the enzyme that basically transforms the cytidine into its inactive metabolite. And this enzyme is present in the gastrointestinal tract, in the liver. So let's say I go to my clinic and decide to drink a bag of the cytidine from my patient IV, likely nothing will happen to me because the cytidine deaminase will destroy the drug. It will inactivate it. So we came with this idea that if we had an inhibitor of CDA, perhaps we could render the decitabine via enteral approach to a similar PK/PD profile that what you get from the IV approach with decitabine. So I have to tell you that this was a lot of fun to do. This took a number of years, this phase 1 trial that you see summarized in the next couple of slides. And what we did was to basically look for a ratio of the decitabine with this cedazuridine, the cytidine deaminase inhibitor, that will give me a close to 100% AUC to that of IV decitabine. So just not to take too much time, if you look here on cohort number 1, we did 20 of DAC, 40 of E727, that's the cedazuridine, and that gave you 35% of the exposure. If you move to cohort 4, we actually went over 144. And then at the end, we went to this ratio of 30-100, that was 85. And then on this study, this is actually another way to visualize this. If you see, this is the IV decitabine in green, and then the other. So this gives you like the AUC of this data. And then eventually, after a phase 2 trial that confirmed the dose of the cedazuridine with the oral decitabine, we designed this trial known as the Ascertain. So this is the phase 3 registration trial of oral decitabine. And this is actually, in my opinion, a very nice analysis. So here we randomized two different sequences of this to this approach. So in the first one, in sequence A, we gave the oral decitabine cedazuridine first on the first cycle, followed by IV decitabine, and then after that, everybody took the oral drug. On the sequence B was the reverse. So this actually allowed for like intra-patient comparison of the PK/PD profile of oral versus IV, and by alternating the sequences, there will be no doubt actually that there was no effect. And what you see here that is actually quite dramatic is that the AUC of both the oral versus the IV was actually identical, 99%. Actually, this is almost kind of difficult to think that is possible. So that was really well done, and it shows actually the investigators did a great job here. When we look at the molecular effects of this drug, that is basically the effect on what we call global hypomethylation that you see here with this line assay, also virtually identical between the IV decitabine and the oral azacitidine. Actually, this was the data that the FDA took to approve this drug. Now, of course, the question is, okay, it's nice, PK is the same, PD is the same, but does it work? So this was data presented by my colleague and friend, Dr. Sabona, in the subsequent ASH meeting a couple of years ago. So what you see is that with single agent oral decitabine, the CR rate was 22%. And then very interestingly, we saw a survival that you see here that is actually around 25 months, 24.7. And people said, well, maybe this response, this survival is because there's a lot of low risk patients, this kind of stuff. But actually at the ASH meeting, we presented in an oral podium very, I think, intriguing data where we analyze actually at the molecular level the patients treated on the ascertain. And as you see here, there's a high frequency of P53 mutated patients, which is actually not what you see in community. Remember, these are the very high risk patients. And then to our surprise, actually, the survival, let's go to the panel on the right, of mutant P53 was basically around 26 months. That is double what you will expect with single agent, for instance, azacitidine, that has been reported to be around 11 months. So we were very surprised about this. Then we asked, okay, maybe it's because a lot of these patients are what we call monoallelic. These are like a little bit better prognosis. But it turns out actually that is not the case, that the majority of these people had this poor risk biallelic feature. And even in that context, actually, survival was around 13 months. That is significantly better than expected. So this needs to be explained, it needs to be reproduced, but there is a signal here actually that this oral compound, for whatever reason, actually is more potent clinically than your conventional hypomethylating agent. So this may not be just like a PK similar type of drug. So we're actually trying to study this. So where we are to finish this part on the oral hypomethylating agents, so oral decitabine cedazuridine, also known as ASTX727, is approved, and that's what we use. But there are two other exciting compounds. One is the CC486. I mentioned that this is approved for AML, but is now being retested in myelodysplastic syndrome. But I think there is a very exciting drug coming called ASTX030. This is actually oral azacitidine cedazuridine, the same concept. We're midway through the phase 1 trial. If this proves to be the case, we will have a true PK oral azacitidine similar to azacitidine. This could be really transformative because the reality is that azacitidine is the most commonly used hypomethylating agent that we have. This actually, the fact that we have this as an oral drug is making a lot of possibilities for clinical trials. So we have studies in low-risk disease. I'm going to show you next combinations with BCL2 inhibitors, but these studies are ongoing, both in MDS and AML, actually. So IDH inhibitors with venetoclax, FLT3 inhibitors, very exciting data with many inhibitors. And we're actually moving into pediatrics. So we now have studies with these compounds in the pediatric setting. Now let's move to the second patient. So this is a little bit younger patient, 70 years of age, 15% blast, the trisomy 8, but this patient has an AXL1 mutation. And this patient potentially is a candidate for a stem cell transplant. You go back again and say, okay, we can do the azacitidine, the decitabine, the oral decitabine cedazuridine. What about a clinical trial? Maybe we could consider a stem cell transplantation. So the field for many years has been looking in high-risk disease at these doublets. So in blue, you see there the two that more recently failed, the Panther trial, the APR trial. I'm going to go through them in 1 second. But we're still some very interesting doublets, like with venetoclax and magrolimab. And I believe my colleague, Dr. Salman, is going to talk about the anti-CD47 stories. So first, a word of caution. So this is the Panther trial, P3001, very important international trial. Everybody was very excited. We thought this was going to make it. And then the surprise is that when you test these doublets in large contemporary international phase 3 trials that are well powered, what you see here actually is that the CR rate today with azacitidine is around 30% in this particular trial. And then the study became negative. So this gives you an idea of the difficulty of kind of designing this type of studies, as we're not 100% sure of survival and response with this kind of compounds today. Now, in parallel, we have the data in AML of the Viale trial, right? This is for older patients, ASA plus venetoclax superior to single agent azacitidine. And we thought, why we cannot incorporate this kind of concept in high risk MDS? So this is actually being right now, as I'm aware of, in 3 different ways. There's a study, international trial called the Verona trial. I'll show you the schema in a second. There's a phase 1 trial that has been presented at ASH a couple of times, but there are 2 publications. So one comes from my group in Lancet Hematology last summer. So this is the study of azacitidine with venetoclax in patients with high-risk MDS. And I think this data is of great interest. So what you see here is that the overall response rate is close to 90%, around 87%. And here we use a very strict criteria of CR that is around, let's say, around 20%. Okay, because there is cytopenia with this combination. But when we look at the survival of these individuals in the high-risk upfront situation, actually has not been reached, and this data continues to mature. Now, what is happening as a consequence of this is that we have now developed a trial. This was presented at the EHA meeting as an oral presentation. The paper is being reviewed of what we call a total oral combination. This is oral decitabine cedazuridine with venetoclax. So can you imagine treating high-risk disease with 2 pills a day for like a few days every few? That's, in my opinion, potentially transformative. So this was again presented not too long ago. Hopefully it will be published soon. But we see, again, really interesting rate of response with this therapy that is actually close to 90%, with actually a very significant rate of cytogenetic responses. And again, the follow-up is short, but a survival that actually has not been really reached at this point. This population, though, is enriched for P53 mutated patients, and there is some question in terms of whether venetoclax should be used or not in this group of patients. So, for instance, this is based on whether they have P53 mutation or not. So in red, the P53 mutated, those without. These actually incredible numbers. And then why I picked this individual with the AXL1 mutation is because Dr. Salman and Dr. Komroki at Moffitt had actually postulated that this AXL1 mutation is sensitive or represents sensitivity to venetoclax-based therapy. And indeed, they were right on target. This is in red. This is really fantastic data in that context. We also saw a very significant fraction of patients going to transplantation. Actually, close to 50% of them were transplanted with this total oral combination. So this also serves as a very powerful bridge to transplantation. Now, this is nice conversation, Neil, but the reality is we need to wait for the results of this phase 3 trial, the Verona trial that you see here. This should read at some point, they say, early next year. This could be a very transformative clinical trial for us, and then it will really enable us to do these total oral combinations and so forth. Now, before I go into the third case and finish our conversation today, remember that I showed you the IBMTR transplant data, and I thought it was kind of meager. The reality is 10 years later, this is again an updated of similar analysis on a transplant in a donor, no donor type of approach. Today, actually, our outcomes with transplantation has really improved significantly compared to that prior slide. And we're transplanting actually a very significant fraction of our patients up to an age, let's say, of around 75 years of age. So we're transplanting older patients, we're transplanting more. There is less toxicity with the transplant, although still we face this problem of relapse in this context. Now, one important thing when we talk about transplant in this disease, and this was also shown by Dr. Salman at ASH a couple of years ago, is this concept of total therapy. So for instance, let's say I have a very powerful doublet like oral decitabine venetoclax, take the patient to transplant. Because of this relapse issue, coming back post-transplant with therapy, it's shown to improve outcomes of our patients. So on the right, on green, this actually, those patients were maintained, in this case, with this drug called APR. But this really shows the power of this total therapy.
Could I just ask, and you were commenting on waiting for more data with the oral combination, but are there clinical situations right now where you're using HMA venetoclax either with, with oral or non-oral HMA outside a clinical trial?
Yes. Okay. So in a meeting like this, to come up front and say I do this off-label maybe is not optimal. Actually, I'm going to tell you what the community does, not me. I see this as a consult every day. Patient in the community with high-risk MDS, they are on an HMA plus venetoclax. This is becoming now accepted. It's actually in the NCCN guidelines. So the reality is we are migrating a lot of our patients off protocol to this more convenient, perhaps more effective oral decitabine. And if we think that this patient is a candidate for venetoclax because, let's say, XL1 mutation or lack of P53 mutation, for sure, off protocol, we will incorporate the BCL2 inhibitor. It's in the NCCN guidelines, and my own research practice here says that we're doubling the response rate. Now, I want to use these 10 seconds because there's a problem, though, with this practicing community, and I would like to use this for a minute, is that many times these patients come to us with an AML schedule of the venetoclax, meaning every day. This is not what we do. This is very dangerous in high-risk MDS. You can do that 1 month. The second month, you exhaust the marrow of these patients. So if whoever is listening to this, please, if you're going to use the venetoclax in MDS, probably you will do 14 days on the first cycle, and very quickly you will go down to like a 5-day schedule. So the number of days is significantly lower in high-risk MDS. And we see this a lot. Very extensive daily venetoclax, patients become pancytopenic, hypocellular, that's a problem.
Please continue.
So let's finish with the third patient. And this is not an upfront patient, it's a high-risk patient in second line. But this example, I think, gives you an idea of maybe where the field is going to go and the power of these targeted interventions. So you remember patient 1 was 78, trisomy 8, couple of mutations. You treated him with oral decitabine, got 16 cycles, fantastic response. But now, a couple of years later, this patient is starting to lose response, repeat the bone marrow, blast are 15% with the trisomy 8. But now this patient has acquired an IDH2 mutation. So this is very important. So these mutations can clonally evolve. So just because you have a profile up front doesn't mean that it's going to be identical at relapse. And indeed, it's not infrequent to gain IDH1, IDH2, FLT3 mutations in that particular context. So then you discuss with the patient what to do. HMA failure has a survival of around 4 to 6 months. So you could say, what about palliative care? Or what about maybe consideration of a clinical trial? Or what about if you could somehow obtain the IDH2 inhibitor, in this case, enacidinib, for your patient? So these are some of the interventions that you could target today. So IDH2, IDH1, FLT3. The others are experimental, so let's not discuss them. But we actually tested this at MD Anderson a couple of years ago, as you can see from this paper in collaboration with Corny DiNardo, where we did a study in high-risk MDS with enacidinib, and we had 2 cohorts. One in combination with azacitidine that you see there, and then a second that is the HMA failure. That will be the case for this patient with single-agent enacidinib. And what is incredible is that the survival of this group of patients with monotherapy with enacidinib for this IDH2 mutated HMA failure, as you can see there on the left, is actually over 21 months. Remember, it's 4 to 6 months with whatever therapies. So this is actually the first time with any intervention, and this is just with a single agent targeted approach, that we have a survival that is close to 2 years. This is unheard of. So this shows the importance clinically of doing this analysis at the molecular level, trying to see if, because this happens in around 30 to 40% of your patients, if there is some way to really do some effective therapy. And if you're going to ask me the question, Neil, will I do this off clinical trial? Absolutely. If we can get the drugs, these are very expensive. You may not be able to get them, but we try in this context, and we're always looking for this kind of mutations in this group of patients. And with that, I think that I covered everything that I wanted to discuss.
Just a follow-up question. Do you see a differentiation syndrome with MDS when you use IDH inhibitors?
Not to the extent that you see in AML. Remember, MDS is more like a bone marrow failure situation, but you have to pay attention. So what I do the first month, I will maybe make sure that I monitor this white count at least once a week, the first 4 weeks. So it's not that frequent, but it can happen. So you cannot just give the pill and say, come back in 1 month. So the first month, you really need to monitor those patients for that particular toxicity.
One other thing I want to ask you is, I'm assuming that the cases were more scenarios, not actual patients, or the actual.
They're actually
patients?
all actual patients.
I was just curious what the current status is of the 3 patients.
So the patient on the IDH2 intervention is still alive. The patient with the AXL1 mutation went for transplant and is around day 60 flying through transplantation. So, and that's the first patient actually got the oral decitabine and then relapsed. So those are actually 3 situations of 2 patients. They are both alive and doing very well.